Good morning, and thank you for the opportunity to present our team's project. Our project is improving patient experience through leadership rounding in Los Angeles County hospitals. Our agenda will run as follows. We will introduce you to our team, cover our project's goals, give you some background and data. Then we'll provide you with our recommendation and an example of our tool, followed by a question and answer session. This is our team. First, we have Vibiana Navarro, who's the Treasurer and Tax Collector's HR Manager. We have Dr. Lucille Rayford, Nursing Director with the Department of Public Health. Mark Medulla, Clinical Nursing Director at Harbor UCLA Medical Center. And my name is Frank Diaz Jr. I'm a Chief Appraiser with the Los Angeles County Assessor's Office. Our goal is to implement a formal process for hospital leaders to engage with staff and patients in our county-operated hospitals. That way, it'll improve the care patient's experience. Why? Why is this needed in our county hospitals? Well, currently, the Department of Health Services has no standardized process of communication for nursing leaders to engage with stakeholders in patient health. Now, we've all been a patient in a hospital, or unfortunately in the future may be one. Hopefully you've received the best care and attention while you stay there. Sometimes the little things make all the difference. Those extra steps a health professional took to give you care, such as asking when you last used the restroom, asking if you need assistance to walk to the bathroom, asking about your medication or pain and comfort levels, even giving you proper instruction to complete your recuperation at home. Some important figures to digest. Johns Hopkins Armstrong Institute for Patient Safety and Quality found the poor hospital performance on 16 patient safety measures used to assign hospital grades caused more than 161 deaths annually. Annually in the United States of America, there are between 700,000 and 1 million patient falls in our hospitals, resulting in 250,000 injuries and unfortunately up to 11,000 deaths. Even the federal government penalized 774 hospitals for having the highest complications. They had high rates of patient infections or other potential avoidable medical complications. These hospitals, which include some of the nation's marquee medical centers, will lose 1% of their Medicare payments over 12 months. Even our own Los Angeles County Department of Health Services incurred litigation expenses in excess of $54 million between the 2016-17 fiscal year and the 2019-20 fiscal year. Now, Dr. Lucille Rayford will discuss improvements in inpatient scoring.
Thank you, Frank, and good morning. Even an incremental improvement in roundings and patient engagements may have a significant impact on falls, ulcers, and other avoidable injuries in our hospitals, which may lead to reduce the litigation costs mentioned by Frank. Our county health service team does an outstanding job, and with everything, there's always room for improvement. Nurses have the potential to positively or negatively shape the patient's perception of care. Giving our nurses the tools to improve patient satisfaction and potentially improve feedback is a win-win for the patient and the organization. Any improvements are reflected in patient care, post-care outcomes, and better safety, which results in less injuries while hospitalized. Patient care experience has been elevated in the priorities of healthcare leaders in recent years as organizations have come to understand the rationale for and benefits of improving patients' experience. Healthcare organizations are making greater investments toward improving patients' experience than ever before in time, training, the appointment of executive positions, and most importantly, the day-to-day interactions that are occurring between caregivers and patients. Prior to 2008, there was no standardized method to measure patient satisfaction. Some hospitals had their own survey methods, but were unable to compare results with other facilities. In 2002, the groundwork for the development and ultimate standardization of a patient perspective survey was undertaken by the Center of Medicare and Medicaid Services in partnership with the Agency of Healthcare Research and Quality. In 2008, a standardized patient satisfaction survey, a national patient satisfaction survey, was developed to collect data measuring patients' perception of their hospital experience. The survey is called the Hospital Consumer Assessment of Healthcare Providers and Systems, Hcap. In 2012, a reward system was implemented by CMS for facilities that provided high quality care through the value-based purchasing program in combination with the Affordable Care Act. And in 2016, CMS implemented a star rating system to make it easier for consumers to use the information to spotlight excellence in healthcare quality. The survey is administered to patients 18 and older who were admitted to a medical, surgical, or maternity floor. Hcap is not restricted to Medicare patients. The 29 items standardized survey consists of 6 composition measures, 2 individual items, and 2 global items. As you can see, nursing care directly impacts most of the categories, and I have those categories highlighted in yellow. The survey assesses the primary drivers of adult inpatient satisfaction. Research reveals a direct correlation between nurse communication scores and other metrics in the Hcap survey, indicating that facilities' efforts should focus on improving nurse communication with the patient. This can be accomplished by including management roundings. Hcap is available in several languages and can be implemented in 4 survey modes, each which require multiple attempts to contact the patient. Mail only, telephone only, mixed mail with telephone follow-up, and active interactive voice response. Hcap scores are designed and intended for use at the hospital level for the comparison of hospitals. However, the results can be utilized as a method for nurses to improve their patients' advocacy and care. Goals of the Hcap is to promote transparency, public accountability, and promote consumer choice. It also creates additional incentives for high performance. Finally, Hcap identifies gaps and barriers in nursing patient care. Hospital leadership can assess this information, which can be utilized to develop tools to address the gaps and barriers to improve patient care. Now, Viviane will address data.
Thank you, Lucille, and good morning, everybody. As mentioned earlier, DHS does not have a formal communication process in their hospitals for nursing leaders and staff to engage with staff and patients, known as leadership rounding. Frank earlier provided you with some information on why this is so important, and a little later in the presentation, we're going to explain more in depth how leadership rounding works. Now, considering our goal is to improve the patient experience in county-operated hospitals, we took a closer look at the measurable data from patient satisfaction surveys so that we could narrow down and identify some outcomes of leadership rounding. Firstly, we looked at hospitals within Los Angeles County that have a leadership rounding formal process in place. We chose 2 level 1 trauma centers that would be most comparable to our DHS level 1 trauma centers, Cedars-Sinai and Ronald Reagan UCLA medical centers. We compared the data with Harbor UCLA and LAC USC medical centers, which do not have this process. Now, although the demographics may differ amongst these hospitals, the care and communication with patients should not, and communication is an area that we felt we can strive to improve in. To see a correlation how leadership rounding may impact patient experience, we analyzed the Hcap star ratings of the chosen hospitals from 2017 to 2019. Now, Hcap uses a 5-star scale to compare these hospitals. Basically, the more stars means better quality care. We selected the pre-COVID timeframe, understanding that there were many variables that we know affected the patient experience relating to their hospital stay satisfaction. Now, since Hcap collects a huge selection of data on hospitals measuring all sorts of things, for the purposes of our goal, improving the patient experience, we narrowed down the data and selected categories specifically associated with the communication between nursing staff and the patient, which Lucille touched upon earlier. This chart you see may be a little difficult to see, but what this shows is a 3-year average ratings of the selected hospitals. This tells us that in 7 out of the 10 categories, the hospitals with a leadership rounding process had higher star ratings. This next slide is for 2019. It's not broken down by each hospital, and it shows the star rating comparison for the non-county and county-operated hospitals, those with and without leadership rounding. 2017 and 18, although they're not displayed here, they showed a similar comparison with the county-operated hospitals having lower ratings. So the question is, how do we get more stars? By improving the patient experience. But we ask, how are we going to do that? Well, we feel that with leadership rounding, we can accomplish this. Now, we've been mentioning the term leadership rounding throughout the presentation. To give you a bit more defined description of what this is, basically rounding is just the nurse interactions with patients on a regular schedule to provide aid. Whereas leadership rounding is more of a structured activity whereby executives, nursing leaders, and our hospital leaders intentionally and purposefully engage with staff and patients. To explain more about how and why leadership rounding works, I'm going to pass this over to my colleague, Mark.
Thank you, Vibiana, and good morning, everyone. As previously stated by my colleagues, there is a need for DHS to invest in a consistent way to improve our approach in addressing the patient experience and subsequently affecting for the positive outcome, the patient outcomes. There is evidence from literature to show that one of the factors that can help address and improve the patient's experience captured through Hcaps, as previously mentioned, and even the clinical outcomes is by incorporating a consistent leadership rounding. How can leadership rounding at county hospitals help? Through leadership rounding, as captured here by Nursing Management article, it stated that leadership rounding actually provides opportunities for leaders to observe inefficiencies and address issues real time. As mentioned before, there are literature pointing to evidence that leadership rounding can actually impact the patient's perception of care. Some of the highlights I'm going to mention here is that it improves communication and enhances trust between the nurse and the patient. And it also helps the hospital leadership bridge any gaps of care and any areas that needs improvement. So how do you operationalize the leadership rounding expectation in your area or within an organization? Namely, you need to schedule your rounds. You have to engage frontline and unit leadership, such as a charge nurse or a supervisor or a unit manager. You have to use a rounding tool to keep track. And I'm going to talk about that a little bit later. You have to engage the patients while in the room and have the staff or leadership with you participate in the discussion and the response. You record or document any follow-up items, and you actually need to follow up on these items. Then you disseminate the information to the stakeholders within your organization, such as directors, other unit leadership, and hospital executive leadership. If you're able to, correlating your internal data with that of your hospital's Hcap scores and outcome measures, such as a leapfrog. So this is a sample template that our group focused on when doing the leadership round. This tool has 2 sections, and for the purpose of time, I will not be going over in so much detail every single item that you can see here. However, I invite you later to ask questions, and we welcome clarifications about this form. Now, in the left-hand section, you will see the column stating rounding on orientation to care. And below that, it notes vital behaviors. Now, vital behaviors means that these are what you and the organization expect to see or encourage everyone to be in the same page of. Two sections of this that I will talk about in detail. In this section, this is where upon entering the room, you immediately scan the environment, making sure it is clean and neat. Also, this is where you will scan for the patient's needs for comfort or safety, such as the TV remote or the call light is within reach and is actually working. Making sure that the whiteboard is updated with the basic yet necessary information such as the date, and engage the patient and any family or visitors they may have. Now, in the right-hand section, this is where you will document your observations and rate it from excellent to needs improvement. It also provides you the opportunity to document anything that is not part of the tool, but noted to be of importance or that you notice. If you have any follow-up item, this is also where you can document it. So what does our group and hopefully DHS want to accomplish? Again, pointing out to some literature, leadership rounding has some correlation to some extrinsic employee satisfaction and also improves Hcap scores. It increases trust and interest within the organization. And did I mention that by doing this, it can make a measurable impact on the patient's overall experience. Now, hospital leaders have access to the data with regards to Hcaps. However, data is in retrospect and typically is linked to several different factors. By doing a proactive approach and consistency in leadership roundings, leaders have the opportunity to mitigate any factors that they are able to identify in real time, actually get real-time feedback for improvement, and in doing so, be able to round up a more collaborative approach in addressing the patient experience, the patient outcome, and also engage and also the staff engagement. And what about within the DHS system? We believe that by implementation of this leadership rounding tool, it will require very little in improve the patient experience and care, but also, for example, reduce litigation expenses. So in summation and by some estimation, if we can trim the $54.2 million average litigation cost that was mentioned earlier by Frank, by at least just 5%, we can see roughly about $900,000 in annual savings, which may allow for investment in tablets and other applications to perform, track, and measure the nursing leadership rounding digitally in the future. And with that, we conclude our presentation, and we welcome any questions or clarifications about the presentation. Thank you, everyone.